hemostasis. Today we'll be discussing on disorders of hemostasis. Be looking precisely on primary disorders of primary hemostasis, disorders of secondary hemostasis, and then other disorders of hemostasis. So the learning objective are, by the end of this discourse, should be able to classify and describe the clinical manifestations of disorders of hemostasis, describe the pathophysiology of coagulopathies, which includes both bleeding and thrombotic disorders, enumerate and describe the laboratory tests for evaluating hemostasis, and then contrast typical presentation of patients with platelet disorder versus those with coagulation abnormalities. Okay. So if you can remember in our last discourse, we discussed about primary hemostasis, where we were able to outline the steps that are involved in primary hemostasis into 4 distinct steps. We talked about during the event of any vessel injury, the first step is the transient constriction of the endothelial cells, which is initiated by the endothelium. And the second step involves platelet adhesion, okay, and facilitated by von Willebrand factor and the collagen that are exposed on the subendothelial cells during the event of injury. Okay, so the von Willebrand factor binds to the disrupted blood vessels, the platelets, via the glycoprotein 1B. So the third step was the platelets release of ADP, okay, and thromboxane A2, which stimulates adhesion of the next layers of platelets as recruitment through a positive feedback mechanism and formation of platelet plug inside the vessel. ADP induces platelets to express another receptor, glycoprotein 2B3A, which is needed for platelet aggregation using the fibrinogen as a linking molecule. So that the last step of the primary hemostasis involves the platelets aggregation, that is the platelets plug. So this was what we discussed earlier on primary hemostasis. So to discuss the disorders of primary hemostasis, you should understand that these disorders are those involving these steps, these 4 steps we summarized here. The disorders that can affect primary hemostasis are those conditions that will try to alter these steps that are involved in primary hemostasis. So the abnormalities for primary hemostasis are divided into 2 broad categories. We have those that are due to that are quantitative, and then we have those that are qualitative. So under the quantitative disorders of primary hemostasis, their clinical features include mucosal and skin bleeding. This is how you identify a patient or someone that is having a disorder of primary hemostasis. When you observe the skin, you see some mucosal or skin bleeding. The symptoms of mucosal bleeding include epistaxis, hemoptysis, GI bleeding, hematuria, and menorrhagia. Intracranial bleeding occurs with severe thrombocytopenia. Okay, these are symptoms of mucosal bleeding. We also have symptoms of skin bleeding, that is easy bruising. You can see bruising with mild trauma. Okay, with mild trauma, somebody can show evidence of bruising. Bruising without trauma. There was no physical assault. There was no trauma, but when under the needs of the skin of the patient, you can observe some of these bruises, as you can see on this diagram here. You can see you've been able to notice some persons with some skin bruises that they are not due to trauma, they just occur. We classify them as small pinpoint ones, characterized by small pinpoint bruises. We call them tachia. We have one that is a bit larger than 1 cm, we call them ecchymosis, and then purpura if it's a bit bigger. So these are some of the clinical symptoms you see with individuals that have disorders of primary hemostasis. These are some of the signs, clinical signs, what you can see with your physical eyes. With your physical eyes. Okay, in trying to evaluate primary hemostasis, we do some laboratory investigations, and those laboratory investigations are still those laboratory investigations that will assess those 4 steps that we enumerated in the steps that involve primary hemostasis. We have platelet count, we have bleeding time, we have blood smear to check the platelets number and the morphology. We have bone marrow biopsy. Okay, these are some of the useful laboratory investigation you can carry out in persons suspected of having primary disorder of hemostasis. So some of the disorders of primary hemostasis we have include ITP, immune thrombocytopenia. Immune thrombocytopenia is an autoimmune production of IgG against platelet antigen, glycoprotein 1b3a. You should recall the function of this glycoprotein in platelet aggregation. So in ITP, there is a production of immunoglobulin against these platelet antigens. Okay, so it can be acute or chronic. It is the most common cause of thrombocytopenia in children and adults. Okay, so the pathophysiology entails that the production of autoantibodies are produced by plasma cells in the spleen. The autoantibodies now bind to platelets. Okay, and when they bind to platelets, the body macrophages try to remove them. They are consumed by splenic macrophages, resulting in thrombocytopenia. So there is an production of antibodies against platelets by the body, autoantibodies against platelets. These antibodies bound to the platelets, and these platelets are seen as foreign particles in the body, that they are being removed by the splenic macrophages. And when this happens, it will result in decrease in the number of platelets that is available. That is the immune thrombocytopenia, because it's being orchestrated by autoantibodies. Okay. Just something should do. Okay. Slide refuse to go move. Oh, okay. Okay. We're having some network challenge. There's some network challenge. Okay. Okay, we had some slight network problems. So we talked about the ITP, immune thrombocytopenia, where antibodies are being produced against the platelet antigens, making these platelets to be consumed by the splenic macrophages. And when they are being consumed by the splenic macrophages, it leads to a reduction in the number of platelets. Okay, so some of these conditions can arise in children. Some can arise in children weeks after a viral infection or immunization. The condition is usually self-limited and usually resolved within weeks of presentation. Another form of this ITP, that is that um, the chronic form that normally occurs in adults, usually women of childbearing age. It may be primary or due to SLE, may cause short-lived thrombocytopenia in offspring. To antiplatelet IgG can cross the placenta. Okay, this immunoglobulin can also cross the placenta, affecting the fetus. Okay, so some of the laboratory findings we can uh, observe in this condition of ITP include decreased platelet count. Of course, we should expect that when antibodies are being produced against platelets and the platelets are being mopped up, being consumed by the the macrophages in the spleen, it will definitely lead to reduction in the number of platelets. The laboratory will also find that this laboratory investigation, prothrombin time and activated prothrombin time, they are normal. Yes, they are expected to be normal because this test, the PT, is being used to evaluate the extrinsic parts of the coagulation pathway, and the APTT is used to evaluate the intrinsic parts of the coagulation pathway. And we are still in primary hemostasis disorder laboratory investigations or laboratory findings in primary hemostasis disorder. So we have not involved the coagulation pathway, either the extrinsic or the intrinsic. So we expect that the PT and APTT will still remain normal. Whatever should be abnormal are those things that are involved in that four steps of primary hemostasis. Also, in the laboratory, we can also observe increased megakaryocytes on bone marrow biopsy. It is expected also because during the process of the splenic macrophages consuming the antibody-bound platelets, the number of platelets in the plasma is being reduced, and this will initiate the production of more platelets, releasing even immature platelets into the bloodstream. So these are some of the laboratory pictures you observe in ITP, which is a primary disorder of hemostasis. So the treatment of ITP includes corticosteroids, the use of corticosteroids. Okay, it can decrease the production of these antibodies against platelets. When corticosteroids are used, they can decrease the production of these antibodies against these platelets. This treatment is sometimes children respond very well to this treatment. Adults may show early response, but they often relapse. Okay, the IgG, okay. Another mode of trying to manage this condition of ITP is by in IgG infusion, okay, IVIGG, okay. When these IgG are being given, they can raise the platelet count in symptomatic bleeding, but the effect is short-lived, okay, because what happens exactly is that when these IgG are being given, the macrophages, okay, instead of mopping up the platelets, antibody-bound platelets, they will start to remove this IgG, thereby allowing the platelets more time to be in the circulation. Okay, splenic macrophages start eating the immunoglobulin instead of the IgG, platelet bound with IgG. Another management procedure for ITP is by surgical procedure that involve the removal of the spleen. Okay, you know, we said earlier that ITP is a disorder of primary hemostasis, which is caused by production of autoantibodies against platelet antigen, glycoprotein 2B and 3A. And when these platelets antibodies are bound to the platelets, that the splenic macrophages are the ones that remove these antibody-bound platelets from the circulation. So in trying to manage the condition, they try to, in severe cases that are refractory a bit, they try to remove the spleen. Okay, they try to remove the spleen, which is the primary source for the antibody production and also the site of the destruction of the platelets. So in some severe cases of ITP, okay, they can take a very drastic um, uh, procedure of removing the spleen. Okay. So another disorder of primary hemostasis we have is the microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia. You can see the microangiopathic hemolytic leading to anemia. So it's the pathologic formation of platelet microthrombi in small vessels. Formation of platelet microthrombi in small vessels. Here, platelets are consumed in the formation of the microthrombi. Okay, when microthrombi are being formed in the minute small blood vessels, the platelets are consumed in the process of forming the thrombi, which will lead to reduction in the number of platelets. Why is the anemia there? The anemia is there because the red blood cells are shed as they cross the microthrombi. Those microthrombi that are being formed in small vessels, okay, narrows the lumen of the blood vessels so that when red blood cells try to pass through those parts of the blood vessels that the lumen have been narrowed, these red blood cells can be shared, that they can be lysed, okay, leading to the destruction of the red blood cell, resulting in a hemolytic anemia with schistocytes, that is helmet cells. There are disorders that can result in microangiopathic hemolytic anemia include TTP and HUS. These are some of the two conditions that can give rise to this microangiopathic hemolytic anemia occurring in somebody. Now, TTP is due to decrease Adams TS13. Okay, TTP is due to decreased Adams TS13. Now, Adams TS13 normally the von Willebrand factor that we encounter during the process of addition of platelets is a multimer. Okay, is a multimer, and before it can be released into the bloodstreams, it's being processed by this Adams TS13. Adams TS13 cleaves von Willebrand factor into smaller monomers for eventual degradation. Okay, but in the process of decreased Adams TS13, large uncleaved multimers lead to abnormal platelet adhesion, resulting in microthrombi. So if there is a deficiency of Adams TS13 and the von Willebrand factors that are being released are not broken down into uh, smaller segments, they will come out as large, very large multimers. And when these von Willebrand factor come out as large multimers, they will consume much platelets. Okay, they will attack, more platelets will be adhered to them. Okay, and when that happens, the platelet thrombi that are formed will block the smaller blood vessels, and that is how TTP, thrombotic thrombocytopenic purpura, can occur. We have another condition that can lead to microangiopathic hemolytic anemia, which is HUS, hemolytic uremic syndrome. Is due to endothelial damage by drugs and infection, usually in the brain or the kidney. Classically, it is classically seen in children with E. coli dysentery, that is mucus diarrhea, can result from exposure to undercooked beef. That is the dysentery can result from exposure to undercooked beef. E. coli virotoxin damages endothelial cells, resulting in platelet microthrombi. Okay, when these endothelial cells are being damaged by these E. coli organisms, okay, the subendothelia, which contains the collagen and also the endothelial cells that are being destroyed, will release both their von Willebrand factor and the collagen is exposed, leading to the binding of von Willebrand factor combining with platelets, initiating primary hemostasis. So some of the clinical presentation, some of the clinical findings with microangiopathic hemolytic anemia include fever, renal insufficiency, if it is HUS that is implicated, or CNS abnormalities if a TPP that resulted in the microangiopathic hemolytic anemia. For laboratory findings, we have thrombocytopenia with increased bleeding time. Okay, thrombocytopenia with increased bleeding time. Okay, then we have normal PT and APTT because we are still investigating disorders of primary hemostasis. The PT and APTT are not involved. They are normal in primary disorders of hemostasis. Then we have anemia, which I've said how it occurs with schistocytes. The anemia was occurring in microangiopathic hemolytic anemia due to the sharing of the red blood cells as they cross the microthrombi in small vessels. Then we have increased megakaryocytes on bone marrow biopsy because the reduction in the number of platelets will trigger platelets production from the bone marrow. The treatment for immune thrombocytopenia is usually plasmapheresis and corticosteroids to remove and reduce the autoantibody. So the ITP and the microangiopathic hemolytic anemia we discussed were part of quantitative disorders of primary hemostasis. Okay, they are quantitative disorders of primary hemostasis, and you can see in both conditions the consumption of platelets. The problem is that platelets are being consumed, okay, and the number of platelets reduced in the circulation. And when it's reduced in the circulation, any small injury can result to bleeding. Okay, now we have qualitative disorders of primary hemostasis. We are taking these disorders at definition levels, okay? Because of the class, we are taking these disorders at classification and also definition levels. We are not going into much details. We are not going into too much details. Okay, so we have qualitative disorders of primary hemostasis. We have one Bernard-Soulier syndrome. We have Glanzmann thrombasthenia. We have aspirin ingestion. We have uremia. These are just very few. It's not a comprehensive list. These are just very few of them. So Bernard-Soulier syndrome is a genetic deficiency of glycoprotein 1B. Each time you come across these receptors, you go back and ask yourself, where is this receptor? What is its function? Okay, so in Bernard-Soulier syndrome, there is a genetic deficiency of glycoprotein 1B. And you know that this glycoprotein 1B was the first receptor that was used in platelets adhering to von Willebrand factor. So platelet adhesion is impaired, okay, disrupted because this glycoprotein is deficient. Then blood smear shows mild thrombocytopenia with large platelets. Okay. So we have another condition of qualitative primary hemostasis we call Glanzmann thrombasthenia. Okay, it's also a genetic deficiency of the second receptor, that is glycoprotein 2B3A, which is involved in platelet aggregation. And if this receptor is deficient, that means platelet aggregation will not be able to go ahead. Okay, platelet aggregation will be disrupted. And if platelet aggregation is disrupted, of course, coagulation will not proceed as is expected. We also have aspirin injection. Aspirin inhibits cyclooxygenase. Okay. This cyclooxygenase inhibits the production of thromboxane A2. Okay. And you can remember we said that during the process of primary hemostasis, when platelets are being activated, they release, we said the first one was ADP, and we also talked about the thromboxane A2. So if aspirin is ingested, it inactivates cyclooxygenase, okay, which is involved in the pathway of production of thromboxane A2. So this will eventually lead to lack of thromboxane A2. Okay, so that when platelets is being activated, that thromboxane A2 cannot be released, and it impairs platelet aggregation. Okay, so we have another condition that can lead to microangiopathic, qualitative microangiopathic hemolytic anemia, which is uremia. Okay, uremia is the buildup of waste products. This buildup of waste products disrupts platelet function. Both adhesion and aggregation are impaired. So this is some of the disorders we are going to take for primary hemostasis at this level. We looked at some quantitative. We talked about quantitative, we talked about ITP and microangiopathic hemolytic anemia. And for the qualitative, we talked about Bernard-Soulier syndrome, Glanzmann thrombasthenia, aspirin ingestion, and then uremia. Okay. So we now have the disorders of secondary hemostasis. Like I used to tell you, we are not exhausting it comprehensively. We're just taking it based on our level for now. So disorders of secondary hemostasis. The secondary hemostasis, as you know, we said that primary hemostasis ended with the formation of platelet block. Okay, platelet aggregation, that is platelet block, where fibrinogen was used as a linking molecule. We also state earlier during the process of secondary hemostasis that during the main aim of secondary hemostasis is to stabilize this platelet plug that has been formed. And to do that, the fibrinogen that was used as a linking molecule during the process of platelet aggregation is being converted into fibrin. So when you now look at the processes that are involved in secondary hemostasis, you should be able to tell yourself, what disorders are you expecting? What pathways are you expecting to be affected? So that is how it goes. So that if you view it in that in this aspect, you won't be able to carry primary hemostasis put into secondary hemostasis. For instance, if you encounter ITP and you say, okay, ITP, okay, antibodies are being produced against platelets. So it should be this way. So it's very, very important for you to understand the mechanism of this disorder and at what step of the coagulation pathway are they playing a role. That will tell you how to classify so that you don't miss each for the other. You don't mix it up. So disorders of secondary hemostasis aim to stabilize the weak platelet plug and this occurs via the coagulation cascade. The disorders of secondary hemostasis are usually due to coagulation factor abnormalities. Okay, some of the clinical features we can see are deep tissue bleeding into muscles and joints. Okay, rebleeding after surgical procedures. Okay, some of the laboratory investigation for now, we'll leave it at PT and APTT. We just leave it at those monitoring the extrinsic pathway and those monitoring the intrinsic pathway. This is just the screening test for the secondary pathway of coagulation. So this is our cascade model, waterfall model for the secondary coagulation cascade. You are to at least know the extrinsic pathway, the intrinsic pathway, at what point. Okay, assuming I want to evaluate factor 8, should I use PT or should I use APTT? Okay, what determines whether I should use PT or APTT? So these are some of the things you ask yourself. So we have some disorders of secondary hemostasis. We'll just go through few of them. We have hemophilia. We say that hemophilia is a genetic factor of hemophilia A. No, we have hemophilia A and B. So genetic factor 8 deficiency for hemophilia A. The genetic factor 8 deficiency is sex-linked recessive, predominantly affects male. We shall see that later. It can arise from a new mutation, okay, without any family history. De novo mutation, it can just come up in the population like that, okay. Clinical presentations or clinical finding with hemophilia A, it presents with deep tissue, joint, and post-surgical bleeding. Okay. Clinical severity depends on the degree of deficiency of factor 8. Okay, it's a genetic disorder, and you know that genetic disorder, there are some also individual factors that affect how severe a genetic disorder can be expressed in an individual. You can find two individuals that have hemophilia A, okay? You find out that one person is very, very down, very, very sick. You find out another person managing, thriving very well. So there are still some individual differences when we talk about genetic predisposition. So some may have their factor 8 well reduced, while some, because of some other genetic factors in their system, may not really be so uh, bad with the condition. Mm. It's happening again to our this thing is hanging again. What is the cause of all this? Try to fix it. Okay. Can you hear me? Can you hear me? Okay. Maybe I'll go ahead with this slide. Okay. Okay. So we'll go ahead with this view of the slide because of this network obstruction. Um, so we talked about the clinical presentation for hemophilia. So when you look at this slide precisely, you can see the clinical presentation we are talking about in hemophilia. This is some bleeding into the muscles, okay? Bleeding into joints, bleeding into the joints and into the muscle. These are some of the clinical presentations. And then in severe cases, we have a long-term complication of hemophilia. See how it disables the individuals, disables them, affecting the bones. Okay. So inheritance, hemophilia A and B are X-linked, as we said. They are recessive conditions, meaning the genes that cause hemophilia is on the X chromosome. Okay. Males have one X chromosome, you know that, X and Y. The female have two X chromosomes. The female have two X chromosomes, okay? Hence, hemophilia usually affects males. Okay, why? Because when a male inherits a gene that causes hemophilia on his X chromosome, okay, he does not produce the clotting factor he needs because the Y chromosome does not provide information for the production of factor 8 or factor 9. It's only the X chromosome that provides the information for the production of factor 8 or factor 9. And the male child has only one X. Okay, and if that X he inherited is the one that that is defective in factor 8 gene, okay, you will not be able to make factor 8 or factor 9 because the other Y chromosome cannot give information for the production of factor 8 or factor 9. Okay. When a female inherits a gene that causes hemophilia on one of her X chromosome, she has a second X chromosome, okay, that can give information for the production of factor 8 and factor 9, and therefore one normal gene that produces clotting factor and compensates for the hemophilia gene. These females are said to be carriers of hemophilia, okay, because their extra X chromosome that is good makes them produce factor 8 and factor 9. So if you look at this diagram, I don't know whether my system has picked up. It's not yet. We looked at this diagram. This is an affected father, meaning that he has the defect X chromosome. Okay. He has the defect chromosome, X chromosome, that cannot produce clotting factors. Okay. Unaffected father, unaffected carrier mother. Sorry for the mix-up. Unaffected father, the father is normal. Then unaffected carrier mother. Okay, the woman is unaffected because she has an extra X chromosome which she can use to produce the clotting factors. Okay, so they be able to give rise to upstream, two unaffected, then affected male, because once the male picks up the affected X chromosome from the mother, he goes down with the disorder because he does not have another X chromosome to produce these factors, while the female always have a second X chromosome that is good to help her produce the clotting factors 8 and 9. Okay, so we have laboratory findings. Laboratory findings in hemophilia. We see APTT is increased, normal PT. APTT is increased because we use APTT to monitor the intrinsic pathway of blood coagulation, and factor 8 and factor 9 are on the intrinsic pathway of blood, intrinsic pathway down to common pathway of blood coagulation. Okay, PT is normal because we are not assessing the extrinsic pathway. If we're assessing factor 7, then we'll use PT. So PT is not affected in this case. So factor 8 is reduced, of course, because there is decreased production of factor 8 for the female child. For the male child, sometimes near absence of factor 8. Then we have normal platelet counts and bleeding time, because we are not talking about disorders that are affecting platelets. This is precisely affecting the coagulation pathway because of reduction in factor 8. So the treatment modalities that can be engaged, there are treatment modality can be in form of concentrated factor products. There are different types of them. Okay, there are different types of them. Concentrated factor products, there are different types of them. Okay, can use concentrated factor products. There are different brands of them. Some of the products that are used in treatment of hemophilia are recombinant factor products. That is, these are products that are developed in the lab through DNA technology. Okay, it precludes using human-derived pools of donor source from plasma, because using the concentrated products, these are products normal populations, okay, normal persons, when their plasma is being pulled together from there, they extract these factors, some of cryoprecipitates, okay, they use it. And because of some infections, viral infections, some of them which have not been able to detect in the laboratory. So they came up with a technology of recombinant factor products where they synthesize these things, these factors artificially in the lab. Okay, okay, eliminating the infection from pool products. Factor therapies are infused intravenously through a vein in the arm or parts of the chest. So these patients with hemophilia can also be given prophylaxis. Okay, you don't expect them to come down with bleeding, okay, before they can be given treatments. Sometimes they monitor them. They have their days of attending clinics where they monitor their factor 8 level, especially the boy child that is very active playing. So he has his clinic days. When he goes to the clinic, they monitor the factor 8 level, so that if it is far below what is can lead to bleeding, they'll be able to okay, give him some prophylaxis to prevent coming down with bleeding. So some of the prophylaxis they use is DDAV, DDAVP, the small pressing. Okay, they give this is a synthetic version of vasopressin, a natural antidiuretic hormone. Okay, so it helps stop bleeding in patients with mild hemophilia. It can be used for joint and muscle bleeds, for bleeding in mucus and all that. So they give some prophylaxis to these patients. They don't wait for them to come down with bleeding before they can treat them. They monitor their factor 8 level and try to build it up with some drugs and preventive mechanisms. So another problem we have in the secondary coagulation pathway is coagulation factor inhibitors. Okay, coagulation factor inhibitors. The coagulation factors are in the bloodstream, and these coagulation factors participate in the process of coagulation in the event of any damage to the endothelial cells. But we find out that just like we discussed in the case of platelets, where autoantibodies, okay, bind to platelets, and then these platelets are seen as um, foreign bodies, and they are being consumed by the splenic macrophages. So also we have some antibodies that also inhibit coagulation factors like factor 8, factor 9. We have some antibodies in the body that inhibit these coagulation factors from participating in blood clotting. They will be there, but because these antibodies inhibit them, okay, they won't be they can't participate in the coagulation process. So this antibody, the coagulation inhibitors, contribute to secondary disorder of coagulation because they are attacking the blood coagulation factors. Okay, this is an acquired antibody against coagulation factor, resulting in impaired factor function. Okay, anti-factor 8 is the most common one. The antibody blocking factor 8 is the most common one. Okay, it's similar to factor 8. How to distinguish it? Okay, so what we are trying to say here, in the laboratory, we try to distinguish, is this disorder due to factor 8 deficiency, genetic, or is it as a result of an antibody blocking factor 8? It's not that factor 8 is deficient, but an antibody is blocking them, making them unavailable, still giving the same scenario as if the person is having hemophilia. So in the lab, we try to distinguish these two conditions by simply performing a very simple test we called mixing study. It's also part of a screening test. So what we do in the laboratory is to get the plasma of the patient, okay, and then get a pool plasma of normal people that don't have deficiency of factor 8. Then collect equal volume of the patient plasma, equal volume of the mix of the pooled normal population plasma, then mix them together. When we mix these two samples together, they now form our test sample. Then we carry out APTT investigation with this sample. Okay, if the result comes out that the prolonged APTT in the patient was normalized, okay, we now say yes, it is as a result of factor 8 deficiency, which was supplied from the normal pooled plasma. But if at the end of the APTT evaluation, the APTT is still prolonged, we will say that it's as a result of an inhibitor which is present in the patient plasma. Because if inhibitor is present and you add more factor 8 to the sample, those inhibitors will still inhibit those factor 8 you have added and still make them unavailable to participate in coagulation. So this is how we screen. There are other further investigations to be done, but this is how we immediately screen for these two scenarios before we go ahead to other things. Now, another problem disorder that affects the secondary hemostatic mechanism is what we call von Willebrand disease. Like I said, we are taking all these things at the definition and brief introductory aspect of it. They are very huge topics to be discussed, but we are taking them at the listing stage and as definition stages. So von Willebrand disease is a genetic deficiency. We've already been talking about von Willebrand factor, von Willebrand factor, von Willebrand factor. So the genetic deficiency of von Willebrand factor is what we called von Willebrand disease. It's the most common inherited coagulation disorder. Okay, there are multiple subtypes. There are different types of this von Willebrand disorder. Causes, we have both quantitative and qualitative types of them. The most common type is the autosomal dominant with decreased von Willebrand factor levels. Okay. For this von Willebrand disease, the clinical presentation, it presents with mild mucosal and skin bleeding. Okay, if as you can recall, these are some of the presentation we find in primary disorders of hemostasis. Okay, if you can remember where von Willebrand factor starts its function in the process of coagulation, it starts its function from primary disorder, primary uh, mechanism of hemostasis. That is why we are seeing that the skin is involved and the mucosas. So in the laboratory, we also find since low von Willebrand factor impairs platelet adhesion, okay, there will be increased bleeding time, okay, because there will be platelet adhesion will not be able to occur. Then increased APTT and normal PT, because von Willebrand factor is needed to stabilize factor 8. Okay, that is why APTT is being affected, because factor 8 is also being affected. If von Willebrand factor is not there, factor 8 will be also affected. Platelets will be affected. So APTT will be affected. So abnormal Ristocin test. This is a test that we use to monitor platelet aggregation in normal plasma. So it will be abnormal because platelet adhesion aggregation cannot take place. So some of the treatments, initial treatment, include desmopressin. What it does, what this vasopressin does is to increase the release of von Willebrand factor from the Weber palette bodies of endothelial cells so that they will be available for the coagulation process. We have also vitamin K deficiency. If we have vitamin K deficiency, it affects the secondary is classified under secondary disorder of hemostasis. Normally, vitamin K is necessary for the gamma carboxylation of vitamins 2, 7, 9, 10, and protein C and S. So if there is deficiency of vitamin K, this coagulation factors are not available. Then deficiency of vitamin K can occur in newborn babies. Okay, vitamin K is generated from gut bacteria, but newborn babies' gut, intestine, like they are sterile, so they can't produce vitamin K. Also, with people that take long antibiotics, there are some people that are addicted. Any small thing you take antibiotics, any small thing you take antibiotics, you're killing your gut flora. Okay, and you can come down with vitamin K deficiency and come down with all this a disorder of coagulation, and then also malabsorption fat soluble vitamins. Okay, in case of liver failure, we can also encounter secondary disorder of hemostasis because it will lead to decreased production of the coagulation factors, decreased activation of vitamin K by epoxide reductase. So liver failure affects coagulation factors. Okay, so we're going to briefly look at some laboratory investigations. Okay, briefly look at some laboratory investigations. So in the lab, we evaluate this coagulation mechanism based on the clinical presentation of the patient. We have some of these tests. We have the bleeding time. The bleeding time is used for predicting the risk of bleeding in relation to surgery. Okay, before somebody will undergo a surgical procedure, they will carry out bleeding time to evaluate the possibility or likelihood of the patient bleeding profusely or uncontrollably, either during the process of the surgery or after the surgery. Okay, but we'll also see the disadvantage of this procedure, that it is difficult to standardize. It has wide intra and inter-assay variability. Okay, There are two basic principles of this test. We have the IVY method and we have the ear loop or Duke's method, depending on where the incision is being carried out. Okay, to carry out the IV method, pressure curve on the upper arm and inflate to 40 millimeters of mercury blood pressure. Then use disposable lancet to make two separate cuts into the forearm apart in quick succession and start a stopwatch. Use filter paper to draw off the blood every 30 seconds. The time when the incision is made until the bleeding stop is called the bleeding time. Now we have also the ear loop. Okay, the ear loop, which is the Duke's method. Instead of using the forearm, it's being applied on the ear. And the range, normal range for the bleeding time is usually 2 to 7 minutes. Okay, so this is a diagram representing what we have discussed, what we have stated earlier. You see the pressure cuff that is being applied, inflated to 40 millimeters of mercury. And this at this position, they use lancets, pointed needle head to do incisions. Okay, after that, they now use the filter paper to be like absorbing the blood that is coming out until it stops oozing out. Then you take the time. So, but this process has the bleeding time is altered in thrombocytopenia when the platelet count is low, because this process of bleeding involves platelets. Okay, it is altered in von Willebrand disease because in von Willebrand disease, the von Willebrand factor may not be available and this process will be affected. Inherited platelet function disorder, of course, the platelets are involved. Acquired platelet function disorder, in some blood clotting or connective tissue disorders. Drugs. These are some of the factors that can affect this process. Then the advantage and disadvantage of this process are there. The advantage is that it is the only diagnostic test assessing platelet function in vivo. Okay, it is simple, as you can see, it is fast, it is a bedside test. Okay, does not imply sample manipulation. You don't have to collect the blood sample. It assesses platelet function in the presence of all the cellular components involved. It assesses platelet function under flow condition. Okay, so that is a very big advantage. Then the disadvantage includes low reproducibility, in the sense that the same individual can perform this procedure in a time and in next time gets different results. So it has low reproducibility, wide variation of the normal range, if you can imagine 2 to 7, requires skilled technician. It is strongly influenced by many variables. Okay, the skin thickness, room temperature, venous pressure, position and orientation of the skin wound, patient cooperation. A lot of factors can influence the results. It is invasive, very, very invasive, and may leave scars. So those are the advantage and disadvantage of the process. So we have prothrombin time, which was described by Quick in 1935 to measure prothrombin time. It is sensitive to abnormalities of factors 7, 10, 5, 2, and fibrinogen, from the extrinsic pathway down to the common pathway. It measures the activities of the extrinsic and the common pathway. It is can be a one-stage based assay upon the time required for a fibrin clot to form after the addition of tissue factor, phospholipid, and calcium to decalcified patient poor plasma. There are different, for now, we use commercially prepared reagents. So depending on the reagents you buy, you follow the manufacturer's procedure. But the basic principle is that the blood is collected in trisodium citrate. Okay, spin needs to remove the platelets, generate platelet plasma, which is used depending on the manufacturer's instruction. You now carry out the PT. So the principle, it measures the activity of the extrinsic and common pathway of coagulation, and therefore depends on the functional activities of factors 7, 10, 5, 2, and fibrinogen. Okay, the method, which depends on the manufacturer, but basically platelet poor plasma plus tissue factor, okay, containing phospholipid to replace platelet phospholipid at 37 degrees centigrade. Calcium chloride is added. The stopwatch then observe the clots, or if you are using an automated instrument, it will detect the clots and stop the reaction. Reference range usually between 13 to 15. Okay, the PT reference range depends upon a number of variables. The source of tissue factor, is it human or is it rabbit? The exact technique used, is it manual, semi-automated, or fully automated? Method of endpoint detection, some are optical, some are mechanical. Okay, you will see all this when you practice when you do your project and you carry out the PT and APTT. You will be able to just see all these things. The PT forms the basis for monitoring oral vitamin K antagonist. For example, the warfarins, okay, is the PT that is used in monitoring vitamin K. Okay, where we also calculate the INR, okay, the international normalized ratio, using the ISI. Okay, so these are commercially standardized products. So the INR is the PT ratio of the sample compared to a normal, corrected for the sensitivity of the thromboplastin used in the test. Okay, this is how we calculate the INR. When you give the PT of the patient, you also calculate the INR for the clinician, because they need it when they are monitoring patients on warfarin. Then for patients that are not taking the vitamin K antagonist, their value should be around 1. For those that are on oral anticoagulants, usually between 2 to 4.5. So it depends. So we have the activated, lastly, we have the activated partial thromboplastin time, initially named kaolin cephalin clotting time or partial thromboplastin time with kaolin. These were the previous name, but now call it activated partial thromboplastin time, APTT. The principle is that it measures the activity of the intrinsic and the common pathway of coagulation, and therefore depends on the functional activity of factors 12, 9, 8, and then down the common pathway 10, 5, 2, and fibrinogen. These are the factors that contribute to whether it is reduced or elevated. Now, the method is also, according to the manufacturer's instructions, we have commercially available kits now, but we still get our PP platelet poor plasma. Then using the kits available, phospholipids and a contact activator kaolin is added, followed by calcium or pre-warmed. With the addition of calcium, clotting is initiated and timing begins. The APTT is the time taken for a fibrin clot to form. Okay, so this is the much we can take. We're not going to much details. This is where we can end it for now. And thank you for listening. If you have any questions, you can go ahead and ask. Odo Benjamin, you are raising your hand. Odo Benjamin, you're raising your hand. Can you hear me? Odo Benjamin.
Okay, good evening, ma.
Good evening. How are you?
Very
Odo
fine, ma.
Benjamin first. Odo Benjamin first. So that
Alright.
I can't hear you. Hmm? I can't hear you. Any other person?
Can you hear me
Talk
now?
to the person. Yes.
Good evening. I have
Good
question.
evening. Good evening.
All right. When you are talking about